All right, let's get into these revision notes you've shared. Today, it's a deep dive specifically into branchial cysts.
That's right. We're aiming to really unpack these notes for you, pull out the most important bits for revision, covering the essentials from definition right through to management.
Exactly, boiling it down. So definition, causes, how they present, investigations, treatment, and the outlook, all the key stuff. So starting right at the beginning, what exactly is a branchial cyst? What's the core takeaway from your notes?
Okay, so at its core, it's a congenital cystic mass. Congenital meaning, well, it originates during development, even if it's not seen right at birth.
Congenital, got it. And where do they actually come from?
They develop from remnants, sort of leftover tissue from the embryonic branchial arches. Think early development stuff.
Oh, okay.
And location-wise, they're typically found along the sides of the neck. Inside the lining is usually squamous or respiratory epithelium. The notes also flag early that treatment often means surgical excision.
All right, surgery comes up quickly. It's fascinating that it's leftover embryonic tissue, but why does that happen? What's the actual cause, the etiology?
Well, the notes actually state the exact cause is unclear. It's definitely linked to that abnormal development of the branchial arches.
Hmm.
There might be some genetic factors involved that's not fully mapped out. And importantly, your notes highlight that it's usually sporadic.
Sporadic, meaning not really linked to the lifestyle or environment.
Exactly. No clear risk factors like that are mentioned.
Okay, so it's a remnant. What's happening inside pathologically to make it a cyst?
Basically, these leftover remnants form a sealed-off sac, a cystic structure. It fills up with fluid, could be clear, could be sort of mucoid,
Okay.
and it's lined by those epithelial cells we mentioned. Symptoms really only tend to kick in if it gets bigger or, quite commonly, if it gets infected. That's the trigger point often.
Right, infection seems key. How common are they? And who typically gets them, epidemiology-wise?
The notes say the exact prevalence isn't super well documented, but they are considered common congenital anomalies.
Common. Okay.
You often see them detected first in childhood or adolescence, but they really can show up at any age, maybe slightly more frequent in younger people overall.
Gotcha. So clinically, what are we actually looking for? How does it present?
Typically, it's a painless lump, feels soft, usually mobile, and again, located along the side of the neck.
Painless, soft, mobile side of the neck.
Yeah, and remember, even though it's congenital, it might not be obvious until later. The key thing is size can vary, and it can suddenly enlarge or get infected.
Ah, so infection again.
Exactly. If it gets infected, then you see the pain, the redness, inflammation around it. That's often what brings people to the doctor.
Okay, but a lump on the neck could
Yeah.
be other things too, right? What are the main differential diagnoses listed in your notes?
Absolutely critical point. The notes mention a few key things to rule out. Thyroglossal duct cysts, those are usually midline, which helps differentiate.
Line, right.
Also, dermoid cysts, simple and large lymph nodes, lymphadenopathy, which is very common, lipomas, fatty lumps, and some other rare congenital cystic things. Distinguishing is obviously important.
Makes sense. So how do we confirm it is a branchial cyst? What investigations are used?
Imaging is usually the first port of call. Ultrasound is often very good for cysts. CT scans can also give more detail on location and size.
And what about sampling it?
That would be fine needle aspiration, FNA. A thin needle takes a sample of the fluid or cells. This is particularly useful if you suspect infection, or much more rarely if there's any concern about malignancy.
Okay, moving on to management. Your notes mention the UK context. What's the usual approach?
Right, the primary treatment, especially if it's causing symptoms, getting infected, or enlarging, is surgical excision.
Surgery again.
Yes. And here's a really high yield point from your notes. The goal is complete removal. Not just the cyst, but any associated tract connecting back to where it originated.
Why is that so important? The tract.
To prevent recurrence. If you leave part of the tract behind, the cyst can just reform. That's a major reason for failure. If it's actively infected, they'll usually treat with antibiotics first, let it cool down before surgery.
Got it. Settle the infection, then excise completely. So what's the outlook? Prognosis and any complications to watch for?
Prognosis is generally excellent with proper surgical management. Complete excision usually resolves symptoms, and the risk of it coming back is low.
That's good news.
Yeah, complications. Well, infection or abscess formation can happen. Sometimes that's the first presentation. Recurrence, as we said, if excision isn't complete. Then there are the general risks of neck surgery, potential injury to nerves or blood vessels nearby, cosmetic scarring, and the notes do mention, importantly, that very rare possibility of malignancy developing within the cyst wall itself.
Wow. Okay, so rare, but something to be aware of. We've really covered the key points from your notes there. Definition, origin, presentation, diagnosis, management, outcome. A solid revision foundation.
Absolutely. Straight from your material, hitting those high-yield facts.
So thinking about all that, especially maybe the need for complete excision or that rare malignancy risk, what's the one thing you'll focus on locking down first from this?
Good question to mull over as you revise.
Indeed. Well, thank you for letting us dive into your notes today. It's been really useful.
My pleasure. Happy revising.
And for everyone listening, don't forget to check out PassThemSRA.com and FreeMSRA.com for more resources.